Today it's Dr. Nawaf and me. We're presenting a case for EDGE procedure, ERCP directed gastroenterostomy. So this patient is a 47-year-old female post history of lymphoma or leukemia actually, and history of liver transplant as well. So she presented with recurrent right upper quadrant epigastric pain and cholestatic pattern liver enzymes. Images showed dilated CBD, ultrasound, MRCP showed distal CBD strictures. So first referred to hepatology because her bilirubin is normal. We just want to make sure that we really need to work up the distal CBD stricture and open it up before any, and to rule out any hepatological causes of her cholestatic liver pattern. And it has been ruled out and referred by hepatologist to decompress her biliary tree and to put a stent and to evaluate the stricture as well, as she will start continue the treatment for post liver transplant.
So as you mentioned, this patient goes through ANWAI, which is mean altered anatomy. So we need ERCP and altered anatomy to evaluate distal CBD stricture. Basically, as you know, the options is enteroscopy assisted ERCP or laparoscopic. This patient already post-lab chole, so the laparoscopy is not that option. And all of us are aware about the failure of enteroscopy assist. So if we compare the successful of both procedure, EDGE or laparoscopic, they are almost the same. But in case if we need lab chole, we can consider laparoscopic assist. Otherwise, we have to avoid the invasiveness of laparoscopic approach.
And maybe Nawaf, we can just show them the endoscopic view. So one of the challenges, this patient underwent sleeve gastrectomy first and then Roux-en-Y gastric bypass. So we only have a small pouch of a stomach with also a previous suture line for her sleeve gastrectomy, and then we have the gastrojejunostomy and anastomosis for the efferent limb of the Roux-en-Y gastric bypass. So we are at the pouch now and trying to look for the isolated part of the stomach.
So we are in the gastric pouch, which is the remnant pouch. So we are trying to identify the excluded stomach actually. So usually they are appear like the star shape. So if you can see now with us, this shape. So most probably we are dealing with the excluded stomach. What do you think, guys?
So I think we have to make it a bit and see on the fluoroscopy, but it does give you that nice star sign of the excluded stomach, and that's one of the signs that makes you differentiate between colon or the excluded stomach as well.
So what we're gonna do, we'll use a 19 gauge needle, we'll puncture that structure, we'll inject contrast under fluoroscopy, and if it's the excluded stomach, we're gonna inflate it till we reach the maximum so we can create gastric anastomosis by using hot lamps.
So we'll go ahead.
Dr.
Nawaf, how are you are sure that you are in the remnant stomach, not in the small bowel?
So I mean, again, as Nawaf mentioned, can we have the fluoro picture as well? So you can see the layers of the gastric wall here. So basically the isolated stomach is a body and antrum. So they may appear as a star shape initially, and this contain a little bit fluid inside that we will inflate, and also we will also confirm with the fluoroscopy. So we will inject as well contrast, and we see it, then we can see the stomach, the contrast going from the body of the stomach into the excluded duodenum. So now we can see the needle is in the lumen of the isolated stomach. Can we have the contrast and the methylene blue?
So do you use 22 or 19 gauge?
We use 19 gauge needle.
Can we have the fluoro picture? Yeah.
Do you see the fluoro, guys?
Common is that the flow of injection. So because of the size of the stomach, it's quite deflated because it's not been used for a while. You really want to have a good flow of contrast going through, so you can inflate the stomach and make your life easier later on in the side function.
So you can see the fluoro with us, guys. So inject the contrast. It seems to be clearly we are in the stomach.
Yeah.
So now we're gonna to shift to inflate with the saline and methylene blue. And once we have nice target, we will call you for the lambs, okay? So if you need to go for another room, you can switch. Otherwise, you can stay with us.
So now I'm injecting methylene blue with saline. So the
Figure
contrast
out.
only minimal amount initially just to delineate the isolated stomach. And now we
Can
just
we have
keep
the US
inflating.
in the view, please? Individual, can we have the US in the view?
بس push the needle شوية يا زلمة. شباب, are we live or yeah? You guys still with us?
Yeah, we can see. We can see.
Okay, so now I just keep inflating, keep inflating. Sometimes it's tricky to inflate the stomach that is post-sleeve. So this patient has a sleeve, right? Even including
I
the...
think she has no. Because if you look for now the fluoro, it's clear we are dealing with a large stomach. So probably this is just a classic Roux and Y gastric bypass.
So, Nawaf, Adel, I will just, if I don't have Nawaf and Adel in my hospital, our laparoscopic team are very good. They just, what they do, they put you in the biliary tree, and then they say, do the rest. Is that easier than doing in a small pouch?
I would agree totally, Hamad, with you in the case of there is need for laparoscopic procedure, like you are planning to do a lab cholecystectomy, but keep in this patient consideration, this patient may require multiple ERCP, so we are dealing with a stricture. So we may need to do US, we may need to come back again and put a stent. So in that case, it's very difficult and it's very risky even to do every time laparoscopic. So I think Edge is taking advantage over this.
So I will comment on that also. There's the issue also of organization time consumption, right?
Still going.
I did a case last week in a patient.
We'll just
with
keep
bypass,
injecting.
Same story, needed cholecystectomy and CBD stone, but they don't have EUS. So I had to do it through surgery, through a gastrostomy site, and then do the ERCP. The problem with that is arranging the OR time for you and the surgeon as well. The time of the procedure, we spent like almost an hour and a half to 2 hours adjusting the gastrostomy site and angle. Well, this procedure is like the Nawaf from point A, and hopefully you're going to finish it.
Yes, good.
But it's going to take hopefully less than 20 minutes, 25 minutes. So the time is a factor. Obviously, if the patient has a clear indication, a clear wish that he wants to have a one-stop shop, one-stop procedure, but there's another indication, then that's totally reasonable.
Give me
But
back.
in cases where you don't have to go for a double cholecystectomy,
Access, please.
I think
15.
this is the best choice right now, especially like Dr. Nawaf mentioned, the success of slow bowel across
Yeah.
the ERCP is around 37%. It takes hours as well.
Get the needle down.
So Dr. Nawaf, we're with you. Looks like the stomach is nicely inflated.
So another thing for Dr. Hamad's question, this patient will definitely need a stent. So like a biliary stent to assess her cholestatic pattern if it will improve after stenting or no, to decide about her post-liver transplant medication course. Another thing is now how many stages is to perform this Edge procedure. So maybe we can ask the audience what's their thought about doing a 1-stage or 2-stage in particularly this patient.
So, Nawaf, Adel, what do you think the cause of the stricture? What is your working diagnosis? Why a man who had sleep, had bypass, developed now a stricture? Why?
So this patient has lab chole, okay? And the other issue, she has a leukemia. And her MRCP was concerning about this stricture. So probably we are dealing with an indeterminate biliary stricture so far. So it could be a benign, but it could be a malignant stricture. So it's very difficult for distal CBD stricture to be, can I have the book? To be in the distal CBD post surgery, but I think we have to work her up for that stricture.
So, Adel, in this case, you would go for 2 stages, right? Because there is no urgency to assess today, right?
Absolutely. So a patient has no cholangitis, or impending cholangitis. So it's just an assessment of distal stricture. So we'll just do the lumen-opposing metal stent stage using a hot Axius 15 millimeter diameter. As we know that the 20 millimeter now is out, which is another reason to do a two-stage, because 15 millimeter is
guys, voice up for the fluoroscopy room, but basically what he was saying is that this patient is not in cholangitis, so they can do the access today to the extruded stomach, and then they have to be on a different day. The difference is, if you want to do a direct ERCP today, let's say the patient's in cholangitis, then you would have to suture the access. Okay, or
So now,
by any means of
Saad, can you hear us?
This is not this long.
So now we puncture the excluded stomach, and we are doing the pulling technique as
all the way down.
what Dr. Manuel yesterday mentioned. So we are in, so we push the catheter till the end, and we fix it there. We deploy the first phalange inside the stomach, the excluded stomach, and once we have it clearly, we go back, and you can see even the floor with us if you like, and we pull back the catheter as the regular steps of lamps till we have the deformed shape. Then we fix the catheter again, and we deploy under EOS inside the channel the distal phalange completely. So once we deploy it, I will swab to the endoscopic view, will be try to be away from the mucosa and push the catheter out. So we create now the anastomosis between the gastric, and we are above actually the anastomosis, the small bowel. So we create gastric now anastomosis, and after 2 weeks, we're gonna back and go ERCP through it. Otherwise, if
What size stent did you choose at the end?
I use 15.
Any difference between the last 15 and 20? Any idea?
Yeah. So the issue usually with the edge is the dislodgement risk after we cross by the ERCP. So it seems to be that 20 is less dislodgement in compared to the 15, but if you're gonna to come after 2 weeks and you dilate already, the fistula has been matured. So usually it's not that issue. But if I gonna to use in the same day, I would prefer 20, and I will fix it prior to crossing to the excluded stomach.
So when you would consider to remove it for one? Let's say it's a stone and you get the job done.
Okay. So usually we come after 2 weeks, we do ERCP. If we are done, we remove the lambs prior to 8 weeks. And we do just ABC of the fistula, and we follow it after 4 weeks from the removal. If the fistula persists, we will do endoscopic closure. Otherwise, doesn't need.
And usually we do have different closure devices nowadays.
Can I have dilate? Sorry?
The next system, you will dilate.
No, bigger picture.
You will just
No, we will not dilate because we will not do the ERCP today, because we don't have an emergency to do the ERCP today. So we'll leave the stent in place, and it will dilate by itself.
Because otherwise, if we dilate, there will be a risk of dislodgement, and there is no
Picture.
emergency
Endoscopic here, bigger.
to do that.
Tell me. Sorry again. We can. You mean the lamb's migration? So the lamb's migration is very rare if you can't see the mechanism of anti-migratory in the lambs itself. But it's still there, it's not excluded. But we didn't count it in edge procedure here in our center, and even in the study, the issue is the dislodgement, not the migration, actually.
And if you mean migration during performing an ERCP, it can happen, so that's why it is low risk if we do it after 2 weeks. Even if it's fine, if it migrates,
Bigger picture.
there will be a mature tract between the two isolated stomach, so we can just put another one under direct vision just to facilitate further ERCPs if still needed.
Bigger, yeah. Sorry?
Dr. Sajjad, we cannot hear your voice clearly.
You're just saying that if it is the 20
millimeter has been recalled by the company, so I think it's a perfect strategy now. Use 15.
Give me
That there's no emergency.
balloon injection catheter.
That will be pretty expensive if you go through that. Just a quick question. What do you do with those patients who still have the gallbladder in? Do you ask surgeons to see them? Do you discuss them? They go
So-
for cholecystectomy and mild examination at the same time, or you still go back
We have a
and
wide-
So-
surgeons do the job later?
What I did usually, if I do edge in the gallbladder in place, we do the first ERCP. We ask the surgeon to remove the gallbladder before we remove the lamps itself, and we come back after them, and we clean the biliary tree, and we go out, and we remove the gate with us.
Yeah, I think it's very important to communicate with the surgeon. We also
give me
had a
contrast.
case last week, and I spoke to the surgeon exactly why we do this cholecystectomy in-house, and they're very accommodating.
Just 1 minute.
Happy that they didn't have to look at properly
Inject.
access for you.
No,
Give me
later.
contrast.
So do you have any question for us, Saad, Ammar, the guys?
One question, yeah.
Yeah, go ahead.
One question, we'll take one question, and then we'll have to move to room 1.
Inject.
How do you make sure that you have got the optimal position of the stent? Because subsequently your target is to get the ERCP done. So if you don't have a very good position, subsequently it will be challenging to go through the entrum and also set.
Yeah, I agree totally with you. So I usually target the body of the stomach, and I go with the axis in this place.
Quick, very important question, yes.
So because if you can